And obviously eligibility, checking eligibility. This is the kind of thing that can be done in Huddle the day before. But if someone's calling in on same day, making sure that plan is active. And here's another one. I find what can be very frustrating is that the front desk team gets hurried, and when they're loading a plan into the software and the subscriber information, that field often gets completed by whoever's standing there who brought the child in. And it's almost never the subscriber. So if they would take the time to please ask who the subscriber on the plan is and fill out that field appropriately, and ideally with that person's date of birth, and the correct effective date and term dates, particularly if you're loading a new plan and the old one is there, please don't just term it on the day that patient walks in the door. Almost all of my clients do that. But it actually termed in December or February 1st or what have you. You're saving steps for your billing team from having to go find that information down the road when something blows up with a claim that's denying. So all that stuff's real easy to do when the family is standing right there checking in. And if there are two plans, I think you're probably all aware it's about finding out who's primary and secondary. Some parents will say, oh, this plan, submit to this one first, and the billing team the front desk will just believe it because we want to believe everything our parents say. But often they don't know which plan is primary. So it's easy to figure out if they're married and you use the birthday rule, but sometimes it's just a matter of asking them, are you aware of which plan is primary? And if they don't know, then the billing team can figure that out. But those are good questions to ask while they're standing there in front of you. Also, it's nice to know in Huddle, it's nice to check if that plan is in network. That really is the responsibility of the family to know that. So I try to encourage the people that, yes. Oh, I thought a hand went up. I try to encourage my front desk teams to tell the family when they're standing there, please verify that we are in network, because that is their responsibility to do. Okay, we'll come back to the front desk in a minute, but with our providers, the most helpful thing our providers do is get that claim coded correctly with their primary diagnoses and to get their charts ready to go within a couple of days of time of service. Often we'll find that with some of the practices that providers get behind, it's all very understandable, but if the goal is to get us paid quickly, to get you paid quickly, having those charts sitting there for a couple of weeks, a month, 2 months, 6 months, you can imagine what that does to your revenue. It's not particularly predictable if that's the way you're going about getting your charts ready to go. So obviously we would like to see you, when the information is fresh in your mind, complete your documentation, sign your chart, and get it ready to go out the door. Ideally the next morning, but certainly within 2 to 3 days of time of service. The next thing with the clinical team, we have an internal spreadsheet that so many of us use at PEDS 1 now called our unpostables. And this is particularly helpful kind of in a training environment, or if we take on a new client and we're all still trying to get used to each other. This spreadsheet's been really a nice add, but basically what we're doing is creating a way to communicate with the clinical team to say, here's the reason why this claim can't go out the door right now. And I like to think of this in a way as it's helpful, but also we're all human, right? So if we make a mistake once or twice and that mistake comes back to us to fix, generally we don't make that mistake anymore. So I like to view it a little bit that way, particularly with the front desk. I mean, if they're finding that we can't send a claim out because the card isn't there, the ID number is missing, or it's entered incorrectly, those kinds of things go back to the team, and they'll fix it, and then they'll mark it off as this has been corrected. And we find over time that communication sheet gets shorter and shorter and shorter because people kind of get it now. But with your providers, we'll kick it back to them and say, hey, there's a level 3 and a level 4 on this claim. Which one do you want to send out the door? Or we're missing a diagnosis, or, any number of kinds of things. But it's an easy way to communicate, and it starts to sort of force all of the staff to pay a little bit more attention as we try to get these claims ready to go out. The other thing I want to touch on is the billing the well and the sick. I've been doing this for about 10 years, and I've seen this all over the map. I know that as pediatricians, we're very nice people, and sometimes we just don't want to bill the sick with the well because we don't want the parents to get the copay or the deductible or the cost share that might come along with it. It's understandable. We take those calls and have to explain them to the parents. Having said that, oftentimes you are saving that family from making a separate trip in, right? So if you're doing a med check with a well check, why wouldn't you bill that? It's a convenience to the parent, and you are providing them with a critical service, and you deserve to be reimbursed for it. One thing I would say is that I've seen it overbilled, and I've seen it way underbilled. But I would just say that the key is documentation. If that child comes in and they have something going on that's outside the scope of the well, maybe it's acne, it's under control, they just need to re-up their medication, it's questionable whether you bill something like that. They're obviously low-level, low-complexity, no big deal that you just wouldn't bother. But if it would warrant another visit, if it requires the history, the exam, these are considerations for billing. I will caution you if it's not documented well, and I have seen a client in the past who did not document the add-on sick very well, and they billed out so many of them to this one particular payer that they were flagged. And being flagged is fine, they're going to audit you, but if you haven't documented that correctly, then they have the right, the payer has the right to take all that money back on those add-ons. And it's not fun to get that bill when you're a year down the road and suddenly you owe the payer quite a bit of money. So the solution is really to make sure that you're documenting that appropriately. And I like to encourage my clients to go ahead and have their template set up for the well, and if they're adding the sick, it follows the well. If you just scroll down, it's as though it's a separate visit, and yet they're attached to one another. And that will give you the cover that you need. The other thing we'd like to see our doctors do is to, just make sure that primary diagnosis is listed correctly. We often get some of those external cause codes or T codes or W codes that go out as primary. That's going to come back as deny. So obviously we need a symptom. And the same thing with, sometimes I have payers that will accept as a primary the strep diagnosis or RSV, but I have just as many others who won't, and they want the symptom as primary. So we will kick those back to the providers and say, let's just make sure we're doing that. And as we get used to one another, I'll have providers that will say, look, if it's charted, they have a fever or nasal congestion, please don't bother me, put that on, just swap it, and I can certainly do that. The G code, I don't know how many of you might be using the G code at this point. How many of you? All right, that's great. I asked this question in February, and it was just a few hands. So I don't know about you, but I'm seeing, it depends on the state, but not a lot of the payers are actually reimbursing for that yet. And it's very possible they'll come back in time and reverse that decision and recoup and then repay. But for now, if you're not using that code, you certainly should. And just, you can look at the guidelines and check that information out, but you definitely are dealing with a lot of complexity in childcare now. Things have gotten a little bit more complicated than they used to be, particularly with mental health conditions being added to the plate. So make sure that you are queuing yourself up to be reimbursed for the work that you're doing for these children over the course of their young years. And the other thing I would say that the clinical team can do for their parent population, just to sort of get ahead of questions and challenges, is to communicate with your families up front about those well-combined sick visits. I can't tell you how many times we have to answer calls from parents who are saying, why is there a bill from this date of service? It was a well check. Or, why am I getting a balance on this G code I've never heard of? If you create a flyer or some form of communication, whether you have it up in your patient room or you have them look at it when they check in and sign off on, whatever your approach might be, Getting ahead of that and communicating expectations is a nice to have for your family, and it leaves them feeling a little less blindsided. You know, as we all know, insurance these days is paying just a little bit less on preventative and putting a little bit more out to patient responsibility, and we may be seeing more of that as time goes on. So communicate, communicate. And let's move on to our billing team. Now it's our turn. We've gotten all this great efficiency from our front desk team, and our clinical team is just humming along and getting everything squared away perfectly, and now the claim is in our hands. The first thing we like to see is to automate as much as we can. If you are not enrolled in EFT and ERA, that is, in our minds, an efficiency that you just don't want to do without. And I understand there are certain payers that are going to charge you fees for that, so you really want that virtual card as a payment or a check, but you're going to wait a couple of weeks longer than you would if this is coming in by EFT. So that's why we do encourage automating. So we start by, our team wants to look at our AR constantly. We look weekly at how we're doing, and we use an aging report, and we break it out by payer, and we try to understand what is it 60 days out, what's hanging out here in this basket from here out, and why. And so that's going to force us to go back and start pulling those payers to find out what's sitting there. Obviously, if you have a billing team in-house or however you're going about it, you want to try and divide out your tasks. But make sure everyone understands what they need to do every day, every week, every month, and possibly 4 times a year. And even to track it by having them sort of check off, what's been done, what needs to be done. I've been doing this for a long time, and even I forget sometimes. Oops, I should have run that report this week. So try to track the tasks that need to be taken care of. Divide out your work, again, based on strengths. If someone's just really good with Blue Cross Blue Shield, let them run with it. If someone else is really good with the basket of little tiny payers and they have the relationships already, let them run with that. If you're seeing that there are large write-offs in certain cases, make sure that's passed by leadership. There should be some oversight as to whether or not that's a good idea or legitimate. Keep your spreadsheets of timely filing, your payer rules. Anytime that you think you need to follow up, your team needs to follow up on a claim that they're working on, just encourage them to set a calendar reminder so it pops in and they can see it. They don't forget that 2 weeks later, I really wanted to follow up on that. Otherwise, it could be weeks before that gets touched again. Have leadership review AR regularly to see, what's being touched. Is anything, do we have staff out? It's summer. Are things getting kind of left? Let's watch this and see what's actually happening in real time. And then setting goals for what would we like our AR to look like over time? How quickly do we think we should be getting paid? Set those goals and those benchmarks so that your team has something to work for. And at PEDS 1, we like to try to keep our payments coming in within 30 days for all payers. We want to meet that benchmark. For insurance, over 60 days from time of service, we like to be under 10%, which is not always easy to do, but it is achievable. So it also depends on your efficiencies and your workflow. And then your combination of personal insurance, we like to keep that under 12%. And we'll talk a little bit more about personal as we move on. So let's talk about what happens once that claim has gone out the door. When you start your payment posting, one thing that we learned at PEDS 1 is that when we have a team is payment posting, we want them to fix any denial that they see as they are payment posting. This seems like a little thing, but gone are the days when we just want someone to go in and post what they see and leave any denial just for later. Fix it right there so that that claim will come right back in a week paid and will never hit the AR report. That's an easy thing to do. Also helps you to get paid within a couple of weeks of time of service as opposed to 3 months. We also, after payment posting, ask that our team prove out to make sure that they're reconciling their payments with their deposits. This is also a nice little catch-all. If there's a discrepancy, sometimes it's just that human error. You know, gosh, I missed that one claim on this massive, you know, electronic remittance advice. I'll go back and find it and post it and everything's reconciled. Maybe there's a take back and it forces you to go find that claim and discover whether it's a legitimate take back or not. And if it's not, then you can start fighting with the payer over that. But proving out is a nice way to find all those little cherries. PEDS 1 has created an internal document they call the Denials Management Report. And I've recently started using this myself, and what I like about it is it does allow for easy oversight. It allows you to sort of, in a glance, look to see what's sitting out there unpaid back to a certain date. It also allows you to adjust the spreadsheet so that the oldest claims are at the top, and you can actually work what's sitting out there and has been for too long as quickly as possible. And as you progress through it, you'll get closer and closer to the current day. But this is a nice tool, particularly if you have a staff and you want to oversee what's being done with AR and what's still sitting there. We have an opportunity for notes so that you can see what's wrong with it. It's a very helpful tool. We also have created some spreadsheets for ourselves, some internal spreadsheets. And this is great just for particularly if you have new staff joining a team and for training purposes. But we like to make sure that we understand our payer rules, and we will create spreadsheets with all of our CPT codes on it, and then our payers across the top, and we will indicate how much of it is paid, frequency of payment, whether there are certain diagnosis codes or modifiers that need to be on those codes in order for them to pay. And this is particularly helpful when you get a denial and you want to look back at your insurance rules and go, oh, okay, well, they're actually not going to pay that. We knew that. But this is a really nice tool and very helpful, particularly when you have sub-staff or new staff. Same thing with timely filing. You want this at your fingertips. How quickly do I need to get this claim out? Do I have a year? Do I have 90 days? And then also, how long do I have on corrected claims, on appeals, things of that nature. Just keep that information handy, because particularly with an Aetna, which is often a 90-day, you want to be working Aetna before you hit a payer that has a year, for you to get that out the door. We also run a couple of reports weekly, and this is just to make sure the claim actually left the building, right? We've got claims that are just parked in our software. And if you're checking this weekly, then you're going to be able to get those claims paid within that 30 days that we're looking for. If you leave these and you check them once a month or occasionally, you're just extending the time that it takes to get paid, right? So we love to run claims never submitted to find out why. Same thing with the error report. Often the error report will give you the information you need. Maybe there's something going on with the provider and the credentialing. Maybe it's one of those strange edits that United Healthcare loves to kick back to you. Maybe it's the member is not valid, what have you. But it does allow you that opportunity to very quickly fix it and get it right out the door. And this is a tool that I use sometimes. I personally don't use this a lot, but it's very helpful. The claims submitted over a certain number of times. And I think you would probably put your limit at least at 3, if not 4, to find out what's coming up and why has this claim been submitted so many times. Sometimes it's because you keep checking the payer and it says no claim on file, so you keep sending it out the door over and over. Sometimes it might be that you have a new staff member that doesn't really know that once you have a resolved COB denial that you don't resubmit the claim, you actually just call and get it reprocessed. This can create a bit of a mess, because if you end up with a lot of submissions, most payers will just do what they normally do and deny the multiples as duplicates. But I've had a few occasions when the payer was very sticky about that and said, I'm not going to reprocess your original claim until you void out all the duplicates that you sent me, which is a weird request, but I have seen it a couple of times. But this is also a great training tool. If you find that some of these are being submitted over and over, you go to the staff member who's doing that and you train them on, what they should be doing. And then this is one of my favorites. I like to think when I was first hired by PEDS One, I was told, there isn't a lot that we can't fix if you make a mistake when it comes to claim submissions. And that's always given me a little bit of, it's made me feel better about the work that I do. And I love this report because if something comes up on my ZeroPay, and I run this weekly, I can look at it and find out why. If it's an E&M code or a vaccine admin code or a depression screening code, and I know those things are supposed to be paying, I'm going to go right back to that, pull up the claim and find out why, pend it back to insurance and work the claim rather than just letting it go. And this can be really helpful when you have a lot of auto posting and something just denies. You have no idea. If you don't look, you'll never know. And then the full pay. This is another good one if you're not running this. You want to find out what's paying at the full charge amount in your software and why. I mean, I've had some weird experiences with Aetna, for example. I don't know why that one keeps coming up. But I think Prevnar, which should have been paying sort of in the $350 range, I kept increasing the charge on that, and they were paying every time full charge, $500, $600, $800, $900. I finally called the rep and I said, what's going on here? This is just out of control. And they couldn't figure it out. It took them a year to figure out why they were paying way too much on that vaccine. But the fight with them was, please don't come back to me a year from now and take all that money away, because this is a drain on my client to have to write you a check for $10,000 or whatever it is. So, so far they hadn't done it, so we'll see if that sticks. And then with your team, obviously in the theme of automating, a lot of us got used to, in this business, got used to calling, but now everything is online, so to the extent that your team can use payer sites, you really want them to do that because it's such a time saver. And there's a lot of functionality on them. So also there are bulletins, there are coding updates, guideline updates that are on some of the better, bigger payer websites. And that's so helpful, particularly with like the new telemedicine codes, or hey, we're changing how we roll on the strep lab. We want this diagnosis as primary or whatever. Or we're gonna need a right and left modifier on these ceremin removals from here going forward. Whatever it is, you get the warning, have that, check that, use your payer websites to their advantage. You can also dispute and appeal claims online, which is so great. And I find that this is a great way to upload your proof of timely filing, but also if you have a denial and your EOB doesn't really explain it very well and you're confused about why, go to your payer websites, pull up the claim and read the denial reason, because generally it's so much more clear there. So you get that little Easter egg that you're looking for, so then now you know what you need to do to get it to pay. This is just an example of United Healthcare's, here's your opportunity to submit a corrected claim or to dispute one. This is such a great tool. You can set it to, email you as the response comes. So I definitely have gotten to be a big fan of my payer websites. Availity, for example, this is one thing about Availity, because I have so many payers listed on there. I love is when I get a COB denial, I really like to go look at eligibility for the plan that I know is active, and it often will say who the other payer is and the ID number. So that kind of little cherry is really important. They do have payer chat. I have found that to be not so useful unless it's the simplest, most Mickey Mouse problem you can imagine. But the dispute, appeal, and secure messaging can be a little bit better in terms of communicating with your payer. The small payer websites are great. I sign up for every single payer website I can, and you get a lot more information there than you might think. I've even seen them showing when a check cleared. So if I'm messing around trying to find the check in the scan file or figure out when this actually paid, some of them will actually go that far, which is really pretty cool. And then if you have to resort to calling, this is something we try not to do. But I have found that, like with Blue Cross Blue Shield, it's almost, I can't stand having to call them. And I think it's because of my Southern accent. They always want that alpha prefix, and it never understands me. So I'm like, So I will start with the military alphabet, and it'll take that. But a few of us discovered in the office that, out of frustration, I might have said something bad, actually, into the phone. And it immediately put me into a person. So we started going, whoa, just say something bad loudly, and you'll get a rep right away. Nice trick. It's cathartic, right? And the other thing I would say is, so often when you're calling, your claims rep doesn't really know a lot, and they basically will pull up the EOB that you are looking at and explain to you that it denied, which you already knew, and hey, that is why I called. So one thing I would say is encourage your staff to question everything. Often you are going to educate that rep on the phone. They just don't know much. They're just really there to do the basic minimum. And it might require that you tell them that you are very clear on why this denied, and I need you to make detailed notes to this effect, send it back to the review team, please. And generally they'll do it. So they learn a thing or two from billers who've been at it for a while. No claim on file. And again, this goes back to, please find out what has not gone out the door. And it's not always that straightforward. So you might even look in the PCC software and it says the payer has acknowledged the claim, and yet you're going to the site and you're seeing nothing. It's been weeks, nothing is there. So this is what I was talking about when I said claims submitted multiple times. You can just put it back out the door. But often, if it says it's acknowledged, it was. So sometimes this just warrants calling the payer and saying, it seems you saw this based on my software, and actually it's there. If for some reason it's not, you have some tools, right? Is the payer ID correct? Is the subscriber ID actually correct? Sometimes at the front desk we get to going too quickly and it's a digit off. Name and date of birth. Sometimes the date of birth is not a match and the parent has to take care of that. I tend to, if I've tried this multiple times and I still can't get it through, I will beg them to give me a fax number. And they often will say, well, geez, we don't do that, but we're going to make this exception this time. So take advantage of that and then call them in a week and make sure they've got it. Common denials, telemedicine code changes. How many of you are using the new codes? And are you finding that most of your payers have gone that direction? That's the same. We at PEDS 1, I know in February we were just kind of billing out the way we had been and just testing the water. The guidelines weren't even out per payer on their websites yet, so we were sort of in the dark. Personally, I'm finding that not many payers are using the new codes yet, but as we'll send out a test balloon here and there to a payer, and if it comes back paid, and even if it's not on the guidelines, posted on their website, we will migrate in that direction, but a lot of them seem to be still using the old approach. Timely filing denials. This is one that I think some people will let go. This is not so big of an issue if your providers are quick to get their charts out, but it can be an issue when you have that recoupment that comes in a year later, right? And oh my gosh, I actually have a different plan. Well, timely filing has lapsed at this point. And if you're finding that and you're not pursuing it, just know that all you need to do is go to the new plan, submit the claim, get the denial. It will deny for timely, but then dispute it and send them evidence that you submitted it the first time within timely filing. It was to the wrong payer, but that doesn't really matter. You made that good faith effort. And payers will overturn that and pay it. So don't let that go. Newborn denials. Parents, I like to encourage my front desk team to ask the parent if they give us a plan and the child's not active, if they have that auto coverage. Some of them don't know, and these parents are exhausted, right? Some of them, it's a first child, they have no idea. But if it's auto coverage and they know about it, you obviously want to get the claim out. Sometimes it will deny, but you've called, you've asked, does this have auto coverage, and they will submit it back to the adjuster for payment. What we like to do is at the 30-day mark, we give them, our families, 30 days to get their child on the plan. If they haven't at that point, then we go ahead and send them a bill. And it's really just a reminder, right? I mean, it's once you get a bill, then suddenly you're inspired to get some things done. And that often does the trick. We also would like to send a flyer explaining to parents, particularly new parents, how to go about this. And this can be very helpful, particularly with Medicaid. You know, help them go through the steps so they know what they need to do. And then we've already talked about this, submitting claims for COB denials or for a newborn. You want to be cautious that you're not just resubmitting those claims if you've already sent them out the door once. It would be faster to get paid if you made the call to find out if that claim got there, and if it did, reprocess that one instead of resubmitting, and it's, again, weeks before you can get paid on that claim. Denials for primary EOB, this is another favorite. It used to be that I would just involve the parent, you know, is there another plan? And I long since gave up on that because getting in touch with parents is not easy. Everyone's busy. You know, the best thing, the best use of your time is to go to the website of the plan you know is active and see if they have other insurance information. Many of them do. They'll tell you the plan and the ID number. So then you go verify eligibility. If it's eligible, if they're eligible on that plan, then you can figure out which is primary, you can get it out the door. This is often the case with Medicaid, right? You find out that there is a commercial plan. But Medicaid in the states that I've been working in is great about telling you who's that payer. So I just don't even involve the parent anymore. I just go ahead and get it out the door. And then it will come back and send a secondary if necessary. And then if the plan termed, maybe it was active in the past, but it's now termed and you can see that information, then you can download that and print it out and dispute the claim that denied, right? And usually that will get that one claim paid. My experience has been that you still need the COB denial or the COB update from the parent because future claims submitted are going to continue to deny unless you get them to call and do what the payer wants them to. But I've been able to get the one claim that's sitting in my AAR that I never want to see again paid. Other denials worth mentioning, the no preventative benefits plans. In an ideal world, your front desk team knows this. This is a courtesy. I mean, obviously, people are expected to know their plan. That is their responsibility. But so often the case is that these young parents buy these plans not realizing they don't have any preventative benefits, and they come in the door and they get Prevnar and every expensive vaccine you can imagine, and then they're shocked. So if you're aware of certain plans that often don't have them, keep a list at your front desk and train your front desk to just mention this to the parent. Oh, I've seen this card before. Are you sure this has preventative benefits? And expect them to look that up. Plans that require a PCP, we have encouraged our clinics to rename plans that you load into your software instead of just saying HMO. Have some indication that a PCP is required just in the name of the listing itself. And that's a great prompt for the front desk just to say to the parent when they're standing there, oh, do you know this requires a PCP designation? And do you know if it's your doctor, whoever it is that's in the clinic? And that just cuts down on the time it takes to have parents call and retroactively change this information. And again, getting you paid in 2 weeks as opposed to 6. And then Medicaid plans, I don't think some of the clinics realize that if a different doctor is listed as the PCP for the Medicaids, that doctor will get the credit for whatever's happening in the visit. So you just want to make sure to ask parents as a courtesy to change the doctor to the doctor they're seeing. It's an extra step, but it comes out in your monthly caps. So. And this is a form that I don't use very often. I've probably averaged once a year, the hassle factor form. How many of you know about this form? Okay. I've resorted to this in extreme circumstances, and I'll give you an example. I remember years ago, TRICARE was, I think we had 3 vaccines that TRICARE was paying nothing on. And I called the rep multiple times to try to get to this person and saying, it's not okay to not be paying us for these 3 vaccines, whatever they were. And it was very tough to get in touch with her, very tough to get a response. And after a while, her only real reaction or her only real information was, well, there's just a 0 loaded in the fee schedule. Well, that's not really good enough, is it? So I kept trying and trying and trying to get to her, and I just wasn't getting anywhere. And my doctor said, let's fill out the hassle factor form. I was like, great idea. So I will tell you, after probably 9 months of fighting this situation, this hassle factor form went out, and within 2 weeks, we got a call from her saying, geez, we're now interested to fix this. So it was great. It was not worth a whole lot of money, but it was on principle. You cannot pay me nothing for vaccines that I'm giving to my patient population. So they did load fees in, and they did go back and retroactively pay those claims that they had paid nothing on. So it's a great tool, and it's kind of fun. I love the name of it. Now I'm going to pivot over a little bit to personal because, this is I focus so much on claims, but personal, this is a huge revenue for you. How many of us have high deductible plans, cost shares, co-pays? Those should be collected at the door. So, as a clinic, you want to think about how am I going to go about personal collections. Obviously, we like to encourage credit card on file. It is the wave of the future. It's an automation. It's not a implement it and forget it kind of thing. It requires work, but I would argue a few hours worth of work a week is worth a lot more than just letting those dollars sit there indefinitely. So if you implement credit card on file, it needs to be in your financial policy. Your parents need to sign off on it. You decide how quickly you want to run the cards. Some clinics will run it as soon as a balance is generated. Others are going to let them look at a bill for 30 days and then run it if they don't pay it on their own. But you definitely, in your huddle, your ideal clinical team, your front desk staff would actually look at who's coming in tomorrow. If they have credit card on file, verify it's still active by running it for $1, authorize it. Just see, is this card working? If it's not, that's another thing you ask them when they walk in the door. Can we update your card on file? And if you continue to do that, you're going to have this regular batch of reauthorizations of cards to make sure they're active. If you let them sit, well, you're going to end up right back where you were before you had credit card on file at all, with a lot of denied cards. Time of service payments, obviously self-pay. I've worked with some clients who have moved from sort of the a la carte approach. You charge something on every single line item that goes out on a claim, to a flat rate. And it probably feels scary to do that, but I think if you do it, really smart, do your homework about what your sort of average proceeds are from certain types of visits, you can probably nail it pretty well. You might make a little bit more on one family than make a little less on the other, but it sort of comes out in the wash. But it's a lot easier on your front desk team when they're charging them, and it's a lot easier on your billing team, so they're spending a lot less time at that. So it's worth consideration. Budget plans. This is a big one. I've worked with clients who won't do them at all. If you don't pay your bill, you've got to do that before you walk in the door. And then others that do budget plans and are very generous. And if you think about it, you can end up financing debt for other people, and suddenly you're not just a pediatric clinic, you're a bank. So you've got to determine, where's that sweet spot? Are you going to take $5 a month on a $1,500 balance and take 7 years for that to pay off? Some would say I'd rather take something than nothing. But you want to try to really be careful about how much of that you're doing. And I like to encourage a 3-month payout, 6 at the max. And this is tough. This is a tough one because there's a lot of hardship out there and things are not as easy as, you might like to think that they are on families, particularly these young families. So this requires some real soul searching and choices on the part of the clinic. Fees, missed appointment fees, late fees, obviously you need to decide whether that's culturally what you want to do in your clinic and whether it works. Sometimes it's a nice little tool if you you have a late fee or a missed appointment fee and you forgive it, that family, you've trained that family to call you and cancel the next time, so it can be useful in that respect. Something to think about. And then collections, whether this is a tool that you find useful or, I've had mixed results with collections in the clients that I've worked with, but some people do very well that way. When it comes to billing our families, obviously the first thing we want to do when they check in is if they have a copay to take it right there. That is money you don't have to chase later. Any balances that are due, please, you will never, ever find that it's easier to find money to get paid unless you have the person standing in front of you. And asking them, how would you like to clear your balance today, instead of, can you make a payment today? Just be assumptive. How would you like to pay? Encourage your patient population to use the pre-check-in functionality that's so great. I mean, they can answer a lot of questions. They can get their insurance cards in. If you add you have a balance pay now link, they can take care of all of that before they walk in the door. And I was listening to a clinic yesterday talking at one of the roundtables about how they provide those families who've done the pre-check-in kind of a fast pass. And they use the example of Disney. And they said, if you've done all that and your forms are all in, your balance is clear, as soon as you walk in the door, they take you right to a room while everyone else is sort of standing there checking in and wondering who that VIP was that just buzzed into the room. So we do sort of a standard mail a statement. At 30 days and 60, we will mail a late letter. But we also like to encourage the blast text messaging that I think a lot of clinics are pivoting to, that PCC has set up so that you can let people know about a balance. Some might even take you directly to a site or the portal where you can pay it. But that is a nice feature, and I think you'll find that you get some proceeds from that. Maybe 30% are going to come back that way. People love that convenience of their device, and not many people open their mail, let's be real. So it's a good way to go. We like to make a courtesy call. We'll even email a family and just prompt them that there's a balance due. And generally that has a good effect. And otherwise, we certainly will encourage people, if they can't make the payment, to set up a payment plan while we're talking to them. Back to the front desk, if you've trained them to have some sort of general understanding of how these insurance plans works, it makes it a little easier when someone walks in the door and they don't really understand their insurance that well. If your front desk doesn't understand it either, then you're just sort of dead in the water. You can always transfer them to your billing team, but if your front desk has some basic awareness of high deductible plans, cost shares, all the kinds of ways that we buy insurance, that can help them to explain, well, this looks like it's a deductible payment, and then go from there with the parent. We go back to the morning huddle. We like to encourage the front desk staff to review who's coming in next, what is needed there. Do we need their insurance cards? Do we need to collect a payment? Do we need to update their credit card on file? And if you have done all of that a day or two before they come in, you have certainly increased efficiency in the whole getting paid process. And that is something that presumably they would have time to do, and it's a good use of time. Some of your staff are probably a little bit more comfortable asking for money than others, and if you're just finding that you've got staff who just can't stand to ask people for money when they come in the door, then that goes back to thinking about people's strengths. If you've got someone on staff who has no problem with that, then put them in that position and let them hum. We also like to, at PEDS 1, set up flags and alerts so that the front desk team can see it, not necessarily the doctors, but if you come in to check in and they're opening up a patient account, if there is a billing related flag that's important, like an overdue balance, or this one needs a COB update, whatever it is, train your front desk to mind those flags. Don't just kill the flag and go ahead and schedule. Please address it, even if that means transferring that parent right to billing. I've worked with a clinic in the past who, if there was any kind of billing related flag, balance related, they wouldn't even schedule them. They would send them right to the billing team, and the parent would say, I'm not even sure why I got transferred here. I was just calling in to try to schedule a sick visit. And they were very strict about it, but it trained that parent population. You know, if you think about that, you really are creating a culture. And if the culture is, you know, if you don't want to pay today, you don't have to. You can bet your bottom dollar that you won't see that money anytime soon. But if you're training them to pay your balance when you come, they're not going to be surprised by that transfer. They are going to come in prepared to address that. So it's really just a cultural expectation you're setting up in your patient population. And then planning ahead, having your front desk staff making some are still making reminder calls. You're probably a lot are sending out texts, but set it up so if there's a balance due, it says that in the prompt. You know, we'll see you tomorrow. By the way, there's a balance due. And credit card on file. I've talked to so many clients who are sort of reluctant to add this. It is a whole nother layer, but it's a rewarding layer. And, you know, people are kind of wary of having to leave their card. You'll have some pushback from parents, but look at these statistics. It says percentage of patients that say they will provide a card is 80%. That's massive. And I think it's because a lot of my doctors want me to do that. So it's okay to ask this of your patient population. And I would say this is so accurate. 50% take 3 or more months to pay their medical bills. That's a long time. I mean, this is one of those industries where you're providing a service and you have to wait to get paid. So we'd love to get you paid within 30 days. But credit card on file is one means of doing that. You know, the claim has got to marinate for a couple of weeks. It comes back with a deductible. If we have that card on file, we're going to get you paid really closely to that 30 days from time of service. The amount of cost decrease for the cost of collections when you have credit card on file, that's a lot, 35%. And chasing parents for money and the cost of postage or whatever forms of bills that you're sending out, I can absolutely see how credit card on file is going to reduce that amount. And this sample financial policy was not meant to be read. I only pointed out that I've asked a couple of my clinics to make it possible at each section to initial it in the hopes the parent would read it, because you all know that they aren't. And I haven't read mine. I never read the ones that I'm asked to sign. But particularly when it comes to credit card on file, having them read it and understand how this is going to work. And I find that oftentimes the phone calls I get from parents saying, hey, you ran my card, it is unauthorized, blah, blah, blah. They're so nice. I don't mind getting those calls, and often it's the parent who didn't come in and sign the financial policy who's like freaking out. But when I explain that, hey, you know, this is how we keep from doing missed payment fees or overdue fees, and people love it, and they're always satisfied. They don't mind. And if they do, if we've created some hardship by running the card that month, I've had parents call crying saying, this is bad, I'm overdrawn. We will absolutely refund that immediately. We're not looking to create hardship. So, you know, you will get the very occasional call like that, but it's an easy reversal. And wrapping up, best practices. Train your front desk, as we've discussed, enroll in your EFT and ERA, automate, set your goals, implement your cards on file, and try to get those claims ready to go within a couple of days of time of service. I have a quickie on insurance reimbursement analysis. I love this report in the PCC software, and particularly if I have a new provider coming in, I like to run a quick report a couple of months after they've been hired just to see, are they being paid like they should? Because sometimes they're being grossly underpaid. I have one right now that's being hugely overpaid, and we don't want that. We don't want the bill later, right? So running that report is very helpful. Same thing for your vaccine payer spreadsheet. Once in a while, you want your office manager to just check. Are you being paid at least enough to cover your cost? And the software running an IRA allows you to grab that information quickly. Negative impacts, inconsistent work on your AR, inconsistent focus there. The deductibles, the first of the year is always a tough time. Those deductibles hit, and it's just like, God, what happened to my personal? And credentialing issues, which these days it just takes forever, right? So your doctor is seeing patients long before the payers got them loaded. So it's a drain, but once they're all set up and ready, you get a nice fat check. So positive is just everything we've been talking about. I don't think there's anything new there. And questions, we have about 7 minutes. Anyone have questions? Yeah.
I don't have a lot of experience with newborn claims for like the PPOs because I have a small percentage, but do people have to write like baby boy, mom? Like I'm really confused about writing what name in the field because some of them want to have baby boy or something, or do you write the name of the child, the mom's name? Like, how do you do that?
I will verify the eligibility online, or the front desk will. And if the child is listed as baby boy Jones, I'm going to adjust the name in my software to that and send the claim out. And usually within 30 days, the name has been corrected to the child's actual given name, and then those claims will go out with the given name. But because I just don't want to wait, I'm going to go ahead and get that paid by calling the child baby boy. Yeah. Yes. Other questions?
I have a couple, but can you tell me how to run the zero pay and the full pay report that you were talking about in PCC?
Yes. The question was, can I show you how to run the zero and full pay? And can you stay after for a minute? All right, we're going to do that together. Other questions?
For updating credit card on files, do you recommend the front staff just basically say, hey, this is the credit card I have on file ending in blah, blah, blah? Do people just say this out loud in front of everyone else who's waiting? Like, how do people confidentially update the credit card on file? Or, I mean, yeah.
That's a good question. Jennifer, do you know how they do that? Are you having them write their card number on a piece of paper? No. She makes the token. She's probably running the card and putting the token in. Yes. Yeah.
What if they're not like, what if they don't need to pay that day and they're just there for a preventative service, but you're not paying anything because there's no copay? And then are you still updating it or asking them, like, what's the sort of procedure for the front desk?
We can still make the token if they're not coming in for a card, actually. We're not taking a payment for that day. We can still go ahead and make the token.
You just verbally ask them for the card number, and they're just standing there giving it to you. She was concerned, I think, about privacy.
Gotcha.
Yeah.
Doesn't matter. Okay.
We also, with CardPoint, we can save it. Like we have like an Apple Pay machine where we just say you want to store your credit card on file, and they can tap it, and then it goes to CardPoint to save the token number, and you save the account.
And is that after you've run a balance, though?
No, we can save it, we can store the card on file doing that.
Okay.
Yeah.
Well, that's cool. You might want to talk to her. Yes.
You can just do it as an off instead of a fail.
Oh, yes, exactly. Right. Run it as an.
Like you ask them for a credit card every time they come in.
No, because it's stored in the credit card portal.
Because if it changes, like,
Oh, if they have to change, well, then you want to update it. You typically go back to that card and just take the number out of the field and replace it with a new number.
I think it's just if I should ask my front desk to be doing it every single time.
So what we do is we authorize the card that we have on file. If we have a current Visa, we'll run an auth. Correct.
Okay.
Yes. Authorize it for $1. Just make sure the card's active. Yeah.
I have a couple online questions as well.
Okay.
You mentioned holding a claim for whatever reason it was. Are you moving those claims to a PEDS 1 software, or are you holding them out of PCC software?
Holding a claim.
You mentioned that you would not send a claim if you didn't have something. There was a spreadsheet that you had that you showed up on the screen.
Oh, I think maybe the unpostables?
No? It was
No.
sending a claim. It was, you said you were going to hold this claim because it's incomplete. It didn't have an insurance card. It didn't have, it wasn't.
Right.
It was a build 3 or a 4, I think were your examples.
Okay, yes, I'm going to hold on, I'm not going to send that out until,
Are you holding that out of PEDS 1 software or PCC software?
it's actually in the EHR. So it's just still sitting there parked, saying ready to post, even though I can see that I'm not ready to post it. But I'm going to go back and look I don't like claims sitting in there ready to post. So I'm going to go back. When I'm finished charge posting for the day, I always go back like 2 or 3 weeks and roll through to see what might have been updated and get it out.
In PEDS 1 software?
Correct. Yes. Other questions? Yes.
Yeah, so we've got one question in the chat, which is the hassle form that you talked about.
I barely need this. Is there a way, the hassle form, is this a way to dispute for for a vaccine or procedure not being paid for by the insurance?
Probably not unless you've been working that claim for months and months and months and you just can't get traction. This is probably more of a global problem with a payer. I haven't used it for that purpose, no. I keep going after the provider rep.
I think the other questions have been answered by others in the chat. I
Okay.
asked to repeat it if they'd like your response, but I did have one person who's interested in the reports that you're going to run by staying after, so.
The zero and full pay. Okay. Our time is up, so if you have questions, please feel free to stay back. I've got 5 more PEDS 1 billers back here, so go to any one of them and they can answer your questions. Thank you for coming.